Thank you, Dr. Marian, for this initiative, and thank you, Professor Lakshman Samarnayake, for inviting me over here. My topic for today's session is root canals and jaw bone lesions. I am Dr. Niraj Kinariwala, everyone, and I'm an endodontist from India. I belong to the city of Ahmedabad, which is in the state of Gujarat in India. Those who don't know that India is a culturally beautiful country, and I hope you guys can visit it one day to experience our culture and traditions. I am professor at Canals University, which is based at Ahmedabad, Gujarat. It's a beautiful campus, and in field of endodontics, we have been working since last decade, and we are trying to carry out more research and that is related to endodontics. And in endodontics, we always say that it is a big issue around a small tissue. We are dealing with the pulpal tissue and the periapical layers. To start with today's topic, I'll always say that in endodontics, it's a big issue around a small tissue, and that is the pulpal tissue we are dealing with. As endodontists, it is not only our duty to deal with the endodontic lesion or to manage them, but also to prevent them. So the main aim of our endodontic therapy is elimination and prevention of the pulpal and periapical disease. Last year, we published this book with Springer Publishing House, where we have tried to incorporate digitalization, 3D printing, dynamic navigation, not only for the non-surgical endodontic treatment, but also for the surgical part. But in the preface of this book, we had mentioned for successful endodontic therapy, the heart of the endodontic treatment lies in the disinfection of the root canal system. Any recent technology, any endodontic file, any of a gadget can only take us to the doorway of the root canals. But the success of the root canal treatment solely lies in the cleaning of the root canal system. How efficiently a clinician can clean entire root canal system is going to determine the fate of that tooth. Whenever we take follow-up radiographs of the patient or we take radiographs during the initial consultation, and we see a periapical radiolucency, that is the jawbone lesion that we are going to deal with. And periapical disease can occur usually as a sequel to the unresolved pulpal disease. Whenever there is irreversible pulpitis or pulpal necrosis, all the byproducts will eventually go through the apical foramen to the periapical region, and that will lead to big periapical radiolucency. In this particular case, what you can see, a foreign body reaction can be seen in the mesiobuccal root. When excessive sealer has extruded through the root canal system, that will lead to some foreign body reaction in patient's mouth. It's very important to understand that how entire pulpal disease and periapical disease work so that we can deal with that in much better way. Everything starts with the infection of dental pulp. And when pulp becomes infected, gradually it becomes necrotic, and there are some exudates and byproducts, and they will go through the apical foramen, what we call the Tredelenburg's mountain pass theory. When these exudates pass through the mountains of minor diameter or apical constriction, they will lead to apical reaction. And the initial stage will be apical periodontitis. During the stage of apical periodontitis, it is very important to take care of this disease at the early stage. Unresolved apical periodontitis can get converted into chronic periodontitis, or it can become periapical abscess, granuloma, and eventually it can lead to a cyst formation. And when it becomes a true cyst, then the surgery is the only option for the clinician to deal with it. On your screen, you can see two different schematic representation. In the first representation, there is a periapical pocket cyst due to the communication of the lumen of the cyst with the root canal system. These are the cases where, as a clinician, we don't need to opt for the surgical approach. Just with the non-surgical approach, this disease can be resolved. Only if the root canal system is disinfected properly. And at the same time, the second approach, the second schematic diagram, what you can see when the true cyst has been formed. There is no true communication now. And in such scenario, surgical intervention is the only choice for a clinician. When we talk about root canal, we know that the root canal has very different type of configuration. It is not a single canal. Most of the times it is not a straight canal. There are curvatures, there are few lateral canals, there are accessory canals, there can be apical delta that a clinician has to deal with. It's a very complex structure which Almighty has created. And on a screen, when you can see that a single tooth or a single root can have 3 to 4 different root canals and different portal of exit. As a clinician, it is very important to clean each and every root canal, lateral canal, and the portal of exit. Because when microbiota is existing in that particular canal, that is going to lead to reinfection. That may not get resolved, and end of the day, the tooth may have to be removed. So when we are talking about root canal configuration, it is important to know that on our two-dimensional radiograph that we take as a clinician, sometimes all the canals are not visible. Even the lateral canals are rarely visible. So it is clinician's judgment, the knowledge of anatomy, and efficiency of root canal irrigation is going to decide that what is the fate of the tooth, how long that tooth is going to survive in patient's mouth. Even a single tooth can have different apical diameter in the root canals at the different level. If you look at the sections on the screen, from the cornal part to the apical part, there can be isthmus areas which can also harbor pulpal tissue. And when that pulpal tissue becomes necrotic, it can harbor further microorganisms. Another thing, normally the story of a decayed tooth starts from a class 1 or class 2 dental caries. Whenever enamel is penetrated by dental caries and it is neglected, it reaches dentine. And when it reaches dentine and the disease becomes much more progressive, in such scenario, it is possible that now it is going to extend up to the pulp chamber, and that can reversibly or irreversibly affect the pulpal tissue. Initially, pulp tissue can be affected reversibly, but when it is not being taken care of, it can become irreversible pulpal disease. And irreversible pulpal disease will lead to pulpal necrosis, and that will result into the jawbone lesion, which is the periapical disease. The most commonly found periapical disease or the jawbone lesion is apical periodontitis. And with apical periodontitis, there is always a risk of getting a tooth tender on percussion. That means your patient is not going to chew from that particular tooth. Patient will always complain that, doc, when I'm trying to chew from the tooth, there is some pain. And that is the pathognomonic of apical periodontitis. At this stage, as a clinician, we have two options. Either you relieve that tooth from the occlusion so that the high stresses which are being delivered to that tooth, they are getting relieved, and you identify what is the cause for this periapical disease. Is this a traumatic bite, high occlusal pressure, or that is extension of a pulpal disease that has become now periapical disease? For that, usually we are relying on pulp vitality test. What you can see on your screen is a periapical disease, a lesion which is attached to a maxillary canine. This is the histopathologic diagram for that. And it is showing that there is a pocket cyst. When we say there is a pocket cyst, that means there is a communication with the root canal system. And these are the cases where a surgical approach can be avoided. We can achieve good results only with the non-surgical approach. When we try to magnify and look further into this type of disease, we can really analyze that the biofilms which are formed on the external surface of the root, they are going to be the main causative factor. Biofilm is something which has been constantly neglected in the field of endodontics. Whenever we talk about primary infection of the root canal system or secondary infection of the root canal system, actually we are going to deal with bacterial biofilms, which is having different microbiota on top of it. On your screen right now, you can see different type of jawbone lesion. Either this jawbone lesion can be due to the overextension of your root canal sealer or gutta percha, which can inflict and initiate the foreign body reaction in that particular tooth. Or that can be simply the extension of the apical disease or the pulpal disease. So it is very important to have a good differential diagnosis as a clinician, that which lesion or which type of disease a clinician is going to deal with. That can help a clinician to decide whether to deal with this tooth with a primary endodontic treatment, surgically or non-surgically, whether the tooth has become reinfected and you can still deal with that without any surgical intervention, or now the surgical intervention is must. To sum it up, you need to take proper radiographs, you need to take proper pulp vitality test, and that will help us to decide which type of intervention a clinician should take for a particular jawbone lesion. On your screen right now, what you can see is a radicular cyst which has been caused around the tooth. Whenever we are talking about the jawbone lesion, they can be of two types. Either it can be of odontogenic origin or they can be of non-odontogenic origin. Today, we are going to talk about the jawbone lesion of the odontogenic origin, because the root canals which are getting infected and the extension of the infection eventually becomes a periapical disease or the jawbone lesion. That's what we are actually concerned with. Many times you can see this type of lesion in the ramus of the mandible of the patient, and that is ameloblastoma in this particular case, which has caused even resorption of the roots of a mandibular first molar, tooth number 4-6. It is very important to take not only two-dimensional radiograph, but also the three-dimensional radiograph, particularly CBCT, which are now very widely available in almost all the countries around the world. And clinician can make their life easier, and that treatment plan will entirely depend on the sections of CBCT. When we talk about introducing digitalization into the treatment, it actually starts from the first step, which is the diagnosis. If you are just relying on two-dimensional radiograph for your routine cases, it is not going to work for the jawbone lesion. If you're having any swelling, if your patient complains of pain and you take X-ray and you can see there is a lesion which is involving more than one tooth, always go for a CBCT, and that will show you that exactly which type of lesion is actually present in that particular case. You can take the axial section and the coronal section, and all different sections will show you sagittally that there has to be some expansion in the bony plate in the cases where there is cystic or tumor development is present. What you can see on your screen is a mandibular canine. It was having some periapical pathosis, but somehow due to socioeconomic reason, patient didn't want to save the tooth, and that tooth was extracted. On extracting the tooth on two different aspects, on the buccal and the palatal side, in the figure B and C, we can see that there is some apical granuloma which is attached with that particular tooth. We try to take the histopathologic analysis of that particular granuloma. And we wanted to see what is the main reason that this granuloma is present, and it is not only present around one side of the tooth, it is extending from buccal to the lingual side. And here in figure D, you can see that there is a lateral exit. So the root canal configuration At the cornal end, there is one root canal, and apically, there are two exits of the root canal system. And that's why on both the sides, the periapical lesion has developed. If we want to save this type of tooth, if we want to do efficient root canal for this type of case, it is very important to do good root canal disinfection. It is important to do proper irrigation. And I can always say it cannot be just manual irrigation. It has to be dynamic agitation. You have to either use ultrasonics, you can use lasers, you can use manual dynamic agitation technique. But along with that, sodium hypochlorite, chlorhexidine, EDTA, Qmix, any of disinfecting solution, irrigating solution of clinician's choice, which is having wide or broad antibacterial activity, has to be used and pumped into this little canal. Then only we can achieve desirable outcomes. At the same time, it is very important to highlight that apical periodontitis, when we talk about today's conference, when we are trying to do innovative biological dentistry, it is very important to connect oral disease with the systemic disease. And when I talk about the oral systemic disease or the oral systemic link, it is just not limited to the periodontal disease and oral and systemic disease. It is also more about endodontic disease and the systemic disease. I have done my PhD into the oral and systemic disease. And in our studies, we have found out that the patients who are having more teeth with apical periodontitis, they are more prone to have cardiovascular disease. There are research articles available, and within the last 5 years, it has been proved that whether it is preeclampsia, it is diabetes mellitus, it can be cardiovascular disease, even patient with nephrotic syndrome. When a patient has apical periodontitis, poor oral hygiene, poor oral health will have its own implication on the systemic health of the patient. So we should not just be a dental clinician, but we have to be a dental physician so that we can educate our patient to have a better systemic health. With any of the jawbone lesion, whether it is apical periodontitis, it is periapical abscess, it is periapical granuloma, or periapical cyst, for any of the case, as a clinician, we can have three options. The option number one is the conventional root canal treatment. In case of apical periodontitis, in case of periapical abscess, in case of periapical granuloma, conventional endodontic treatment should be the first option that a clinician should always opt for. When a root canal has already been done and that tooth has now become reinfected with new infection, that is the time when we can decide that now we can go for either non-surgical retreatment or we have to go for the surgical retreatment. And how to decide as a clinician whether they want to go for the non-surgical retreatment or surgical retreatment can be opted, that entirely lies on the radiographic evaluation and deciding which type of disease is present. If a true cyst has been formed, then only surgical retreatment will give you predictable outcome. But if there is periapical abscess, if there is a pocket cyst which is having a communication, in such type of cases, you can still try with the non-surgical retreatment, be more conservative dentist, and try and avoid surgery, and eventually you can introduce surgery if needed.
Mixes with the soda.
It is also important to show you that the root canal disinfection is very important part. When we are going for root canal disinfection, these are the educational videos which we make where we want to show that the middle third of the tooth is the most important part sometimes, which is having the more bulk of the pulpal tissue. When we try to disinfect the tooth, your needle should go 1 mm short of the apex. It is not only the cornal third or the middle third which is important, but the apical third is going to be the main determinant of how good cleaning you have achieved. Different type of needles are being used for irrigation. And normally as endodontist, the needle which we prefer is 30 gauge needle, which is the smallest needle, which can go even in the narrow canals and give you better disinfection in the apical third of the tooth. On your screen, you can see a case where patient has history of trauma 10 years back. No treatment was opted for at that point of time. And right now, maxillary left central and lateral incisor both are calcified in the conal third. So when we take a CBCT, we can see that the root canal is missing. We can just see dentine in the conal third part. And when we go apically on the CBCT, we can see that there is a big periapical radiolucency extending up to the palatal part. When we encounter this type of cases, the treatment approach is very important. This is the case where the very thin palatal plate is left with the patient. If you still try to be conservative dentist, if you still try to do non-surgical root canal treatment and then wait for 6 months and 12 months, there can be even palatal plate perforation. Now, in contemporary endodontics, with this type of cases, we always perform primary endodontic treatment. We do access opening, do cleaning and shaping of the root canal system, definitely use chlorhexidine and sodium hypochlorite. But after obturating the root canal system, on the second day, we opt for endodontic surgery, which is root and dissection. These are the cases where we can see that the lesion is progressive. It started from central and lateral, but now it is extending up to the canine. And if we wait further, even the premolar can also get involved within the next 6 months. In such type of case, surgical intervention is must. And as you can see, a very big periapical radiolucency in this particular section. So what we planned for this particular case was dynamically guided root and dissection surgery. Now, as at the start of the lecture, I mentioned that we try to incorporate digitalization because we want our treatments to be much more predictable. Now, anyone will say that, there is already a lesion. What is the need of incorporating digitalization in this type of case? But as a clinician, for me, there are a couple of challenges. Those who are already into endodontic surgery, they will know that the biggest challenge in endodontic surgery is getting good root and dissection so that we don't compromise the crown root ratio. To maintain good biology of the teeth, to increase longevity of the teeth, it is very important that we can maintain good crown root ratio. And for that, we make sure that we end up resecting only 3 mm of the apical third of the root. At the same time, the root and resection angle is very important. In the conventional root and dissection surgery, 45-degree angle was given. Now with the microsurgery part where we are incorporating magnification for the better outcome, it is important that we achieve 0-degree bevel at the apex. And how to achieve this 0-degree bevel? For that, we need to incorporate this type of digitalization, what you can see on your screen, which will make sure that the root is being resected at the 0-degree angle. Not only central incisor, but also lateral incisor was resected in the same manner. When I talk about dynamic navigation, this is a technology with which we can actually achieve the real-time navigation. What is real-time navigation? When you open up your mobile and you open Google Maps and you want to reach to a certain location, you enter the location, the destination, and the mobile app will show you that you have to go 2 kilometers straight, then take a left turn, then you have to go 500 meters straight and you will reach your destination. The same thing can happen with a digital device which are showing you image-based navigation. So we take CBCT data of the patient, feed in the system, and the system will guide you while you are drilling inside in the real time. So on your screen right now, when you can see the green colored dot is being moved in all the section, there is one sagittal section, one apical section, there is one OPG section as well. And you can see that the green colored dot is moving continuously. So that is showing that during root and dissection, where my drill is moving inside patient's mouth. And that is me on the left-hand side of the screen in the corner, doing apicectomy in the patient. And we can achieve precise 0-degree bevel and proper root and dissection with use of this type of technology. But again, technology can only help you to achieve good root and dissection and osteotomy. But what is the main factor? That is good curettage. When patient is having periapical disease, it is important to do good curettage and remove all the microorganisms and all the defect, all the pathosis from that crypt. And here you can see how beautifully the root and dissection has been achieved in all different dimensions, three-dimensionally. But as I was mentioning, that it is important to see that how periapical curettage is important for the success of the root canal treatment. I think again there is some glitch in the internet and the video is not visible properly. I'll try to play it again. So here you can see that a modified flap has been opened. We have taken a very conservative flap where not only the marginal gingiva but interdental papilla is also preserved. And after that, you can see that some foreign body is being retrieved during apical curettage. So when I showed you the first radiograph, when there was a gutta percha and sealer going beyond the apex, and that led to some foreign body reaction. If that lesion is not resolved by non-surgical mean, we have to do the surgery. And that is the curettage, where you remove the cyst, foreign bodies, and all the infection from the periapical part. It has to be cleaned thoroughly. And again, if you can observe closely, the curate which we are using is having some serrations on top of it. So only the serration will help you to remove all the tissue tags, and you can actually scrap it and reach to the very healthy bone in the apical area. The science of endodontics is very vast, and it is very difficult to compact everything in one small session in 20 minutes. But what I have tried to do in this session is to just give you a glimpse of what we are trying to do with the book. It is not only the etiology of the endodontic disease, but also the clinical part, how to deal with the periapical disease that we want to deal with. And as I mentioned, that we should not consider ourselves only as a dentist, but rather we need to be a dental physician who can help our patient to get a better systemic health as well. You are what you believe yourself to be. Thank you, everyone.